afternoon to everybody. My name is Dr. Henrique FurlanPauna. I'm a third-year resident of ENT in Brazil. I'm here to present to you the otolaryngological findings in a group of patients with rheumatic disease. First of all, I'd like to thank the organizing committee for the invitation to have the opportunity to show our job. This is our group here in Brazil, and I'm here to begin to speak about the high prevalence and the rate worldwide in the functional disability index. The systemic changes involving the connective tissue throughout the body. It's important to remember about the blood vessels, serous and mucous membranes of all areas digestive tract. And the ear, nasal, and ocular symptoms may be the first manifestations of various rheumatic diseases. And the objective of this work is to identify the ENT manifestations in the patients with rheumatic disease that we follow in the Hospital of High Complexity in Brazil. Remember, it's to identify the ENT manifestations, not to give you a new kind of diagnostic process, nothing like that. It's just to identify the ENT manifestations. Here we are talking about the relapsing polychondritis, the lupus, the Wegener's granulomatosis, also known granulomatosis with polyangiitis, followed by the Chapel Hill consensus in 2012, Sjogren's syndrome, and Churg-Strauss syndrome, also known as eosinophilic granulomatous with polyangiitis, also by the Chapel Hill consensus in 2012. We conducted this trial in the second half of 2010. We have the complete clinical and ENT evaluations. What is this? We have the detailed history, the ENT physical examination, followed by the residents in the outpatient ENT. We proceeded the audiometry and tensiometry, and also the flexible nasal fiber laryngoscopy. The assessment was fully standardized and normalized as a filling form during the procedure. And the patients were referred from the Department of Rheumatology randomly. We had 32 patients from this period. The diagnosis was defined by the criteria of the medical guidelines in Brazilian Society of Rheumatology. The mean age was 41.7 years, and the mean disease duration was the 9.12 years of disease, range from 1 to 40. We have 6 tables in this presentation. The first one is about the otological signs and symptoms of the patients. We have to say that 100% of the patients with Sjogren's syndrome have ear pruritus. And for the nasal signs and symptoms, Churg-Strauss, we have 100% of post-nasal drip. The pharyngeal symptoms of the patients, we have to say that 50% of the patients complain with Churg-Strauss syndrome complain about dysphonia, the cough, the dyspnea, hemoptysis, and hawk. We had another head and neck symptoms and signs as a conjunctivitis, headache, and facial paralysis. We have no patients with facial paralysis. And the findings in the ENT examination, we had alterations in the 7% of the patients with Wegener's. Also, we have 100% of the patients with alterations in the rhinoscopy, also in the otoscopy, and Churg-Strauss syndrome is also the rhinoscopy and alterations in the nasofibroscopy. Here we have 100% of the patients complaining about otologic symptoms with Sjogren's, also nasal symptoms and audiometric changing. And Churg-Strauss, also 100% complain about the nasal symptoms. Here I'm presenting for each disease, for 17 patients with Wegener's granulomatosis, we had hearing loss in 53%, and the kind of hearing loss was the bilateral sensorineural pattern. We have also the nasal obstruction as a symptom in almost 65%, and the rhinorrhea in about 60%. Coryza, septal perforations, mucosal edema, and turbinate hypertrophy were the signs that we found in the clinical examination. And another complaint of the patients was the dyspnea and raucousness due to the hyperemia of the posterior pharynx, interarytenoidal edema, and relative degrees of subglottic stenosis. For the relapsing polychondritis, we have 5 patients. Ear itching in about 60%, followed by the tinnitus, hearing loss, and ear fullness in 40% of patients. We also found for the clinical examination opacity of the tympanic membrane, and this kind of hearing loss was the conductive kind because of the opacity and the fibrosis in the membrane, tympanic membrane. The nasal obstruction, rhinorrhea, and sneezing in 40% of the patients was due to coryza, the mucosal edema, pale mucosa, granulation of the turbinate, and the turbinate hypertrophy. Cough, frequent cessation, raucousness, and choking was due to the interarytenoidal edema, paresis of the vocal folds, and laryngeal hyperemia. For Sjogren's syndrome, we have the tinnitus and the ear fullness, complained by 60% of the patients. We have the conductive hearing loss and desquamation in the sternal auditory canal. The nasal obstruction, another complaining, due to the hyperemia, and the edema of the mucosa. And we also found dysphonia and raucousness in the patients, and we also found as a clinical examination salivary gland hypertrophy, dry mouth, and interarytenoidal edema. For lupus, we also found the tinnitus and the hearing loss. We also found both kind of hearing loss in the patients, both conductive and sensorineural. The nasal obstruction and rhinorrhea due to the mucosal edema and the dysphonia. We found the glottic cleft during the phonation with the use of the flexible laryngoscopy, and interarytenoidal edema. The last one, the Scherg-Strauss, we have the conductive kind of hearing loss. We have pale mucosa, turbinate hypertrophy, and coryza in the patients. And we have laryngeal edema, glottic cleft, and secretion in the larynx. The ENT symptoms may represent an early sign of an underdiagnosed disorder that often requires an immediate and aggressive immunosuppressive treatment. We must consider the large time lag between complaints and the correct diagnosis, and more than 1/3 of the patients present systemic manifestations that can include vasculitis, cryoglobulinemia, autoimmune hepatitis, pulmonary fibrosis, CNS involvement, renal tubular acidosis, B-cell lymphomas, and multiple myelomas. The ear damage, we can see the hearing loss with a decreased hearing acuity or discrimination of sounds. It might be uni or bilateral, involving the medium or the high frequencies. It can be the sensorineural, conductive. It might be gradual or sudden hearing loss. We also found vestibular cochlear symptoms, involvement by the vascular lesions in the internal auditory area, and also auricular chondritis in 85% of the cases. The laryngeal involvement is extremely rare, and the symptoms can range from a hoarseness or to respiratory distress. It's due to, you can see from the literature, cricoarytenoid ulceration, stenosis, and edema. And we also see complete vocal fold paralysis by this study of Krause and Guerra-Batista. The nasal involvement, we can see a range from allergic rhinitis, rhinosinusitis, nasal obstruction, epistaxis, perforation, and septal perforation. erosion of the vomer, and crust formation. For the Chug-Strauss syndrome, we have 3 stages. The first one is prodromal stage. We see the patient with asthma and allergy. The second stage is the eosinophilic stage, as the defining of the disease, is the eosinophilia and organic infiltrate by the biopsy. And the third stage is the systemic vasculitis that we can see. The oral manifestations we can see from xerostomia, dryness of the lips, tongue and pharynx, dental caries, and periodontal disease, exactly because of the dry of the mouth. The oral symptoms of dry mouth is present in 86% of the patients, and the eye symptoms is present in 53% of the patients. The Schirmer test or the Rose-Bengal test staining is positive in 46% of the patients. We have also the symmetrical and recurrent parotid gland hypertrophy. This trial is here and to demonstrate the various ENT manifestations. And it's important to observe that the early identification is critical to the early immunosuppressive treatment. That's, I know it's a short, it's a short presentation, but it's to remember that the ENT manifestations, it's also important to an early diagnostic process. Thank you so much.